Welcome again to our treatment sequencing panel. Today we have an extraordinary team of clinicians and NET specialists. I'm Xavier Keutgen. I'm a surgeon at the University of Chicago. And we have Thor Halfdanarson, who is a NET oncologist at Mayo Clinic. We have Erik Mittra, who is a nuclear medicine physician at OHSU. And then we have our own Ahmed, who is an interventional radiologist at the University of Chicago. And last but not least, Andy Liao, who is our neuroendocrine tumor oncologist at the University of Chicago. Welcome to all of you. I'm really excited to have you here. So this is going to be a treatment sequencing panel that is essentially based on two cases in a tumor board style format. So I'm going to go right ahead and let's get this going. So I know we all come from different institutions and we all have a different decision process, but this is how we do it at the University of Chicago. Just to briefly summarize for our patients, when a neuroendocrine tumor is resectable and it's not metastasized, we try to resect them and then we follow those patients. But what we're going to talk about today is mostly those tumors that are not localized and that have distant metastases. And there are several options, as you can see here. We will discuss all of these options if they come up throughout the treatment. So let's go ahead and let's start and jump into the first case. So case one is a 55-year-old male who presented to our clinic with flushing, diarrhea, and lower extremity swelling. I'm going to tell you that he had a urinary 5-HIA, which was very high, and a chromogranin A, which was very high as well. He had a CT scan, which showed, as you can see here, where the blue arrow is, a big mass in the left lobe of the liver. So this obviously suggestive of a small bowel neuroendocrine tumor. He had a biopsy of the liver, which showed a well-differentiated grade 1 neuroendocrine tumor with a Ki-67 of less than 3%. So why don't we start with Thor? What would you recommend the patient has done next? Is there anything in particular, especially with the symptoms that you could read here, that makes you suspicious or that you would want to work up further?
Absolutely. So we have obviously a very strong clinical evidence for active carcinoid syndrome. So we have someone with flushing and diarrhea and with very, very high 5-HIAA. So this tumor is really making a lot of serotonin. So with the lower extremity swelling, before we do really anything to this liver, I would really want an echocardiogram just to see if the cardiac valves are affected by the sort of chronically elevated serotonin. So that is probably what I would start by doing right now.
Fantastic. Believe it or not, we had the same idea. So he did get a TTE actually, which later turned out to be a TE as well. But essentially what that showed was a dilated tricuspid annulus with severe reflux. What that actually means in layman's term is that he had like carcinoid disease of his valve. And so his valve was not competent, which could explain why he had some low extremity swelling. Andy, what would you do in this situation?
Well, I think this patient needs, medical treatment, so systemic therapy for both for the carcinoid syndrome, but also for the tumor itself, to slow down the growth of the tumor. And generally, we consider somatostatin analogs like lenriotide or octreotide OAR in this situation.
Great. Would you send him to a cardiologist with this echocardiography finding, or?
So we definitely need to get our cardiologist involved, especially if we're thinking about other treatment options for the patients for the future, such as surgery.
Okay, so this is exactly what we did. Like Andy said, we started him on long-acting octreotide, and he actually saw the cardiologist who sent him to the cardiac surgeons who thought that it was necessary to fix his valve. So he did undergo a successful valve replacement therapy with cardiac surgery. So what do we do now? Let's go back to Thor. What would you do now? You have a patient that's on long-acting octreotide, this cardiac valve is fixed, low extremity swelling is gone. Anything in particular that you would want to address?
Yeah, so right now I think I would want to know the extent of this disease, and then now I'm thinking in terms of regional therapy, be it the resection or the embolization or some liver-directed therapy. So if we haven't done it already, I would do a GA68 dotatate PET CT or a PET MRI. and just to get a little better idea about the extent of this malignancy. And also, I would inquire about any intermittent symptoms of bowel obstruction, anything to suggest that the primary tumor might be causing problems.
Okay, great. Oz, when you've seen this large mass in the liver, is that something that you could consider for interventional radiology treatment? And if yes, what would you use?
Yeah, absolutely. It's fairly
What's on
large,
here?
as we can see on the CT exam there. And so from an interventional approach, we have sort of two main options. One is percutaneous ablation, which is taking a needle and either burning or freezing the tumor, or intra-arterial therapy. For a lesion this large, if we were sort of asked to intervene on this, I would side with intra-arterial therapy because of how large this is. It would probably not be really effectively treated with ablation because of its size. And among the intra-arterial therapies, the options would include radioembolization or bland embolization. Those would be probably the two main sort of treatment choices.
Great. So he did have an outside dotatate PET-CT, but it showed that there were minimal bone disease and that most of his disease was actually limited to the abdomen. So he had one large liver lesion that lit up, as well as two smaller lesions in the right lobe. And then he had this mesenteric mass as well as the primary, which lit up in the mid-small bowel. So what we did is we actually took him to the operating room, mostly because he also kept to be continuously symptomatic despite being on somatostatin, but we felt that most of his tumor burden being in the abdomen, and because he was a young patient with a good heart, we felt that he was actually a good operative candidate. So we took him to the operating room. He underwent surgical resection of a small bowel neuroendocrine tumor, and he underwent a left hepatectomy, and we ablated two lesions on the right side. So in the meantime, we saw a really steep drop in his serotonin levels. He became asymptomatic. And what do we do now? Andy, in a patient that's asymptomatic after you have debulked him, would you actually consider continuing long-acting octreotide, or would you stop it at this point?
Yeah, so that's a good question. So I guess it depends on how much the surgeon was able to take out, so how much disease is left behind. So if there's still a lot of disease left behind, and maybe if they're kind of still minimally symptomatic, then I probably would favor continuing SSA. If the majority of the disease is resected and asymptomatic, then one option would be just to stop it and to observe. So
Thor, any ways you particularly do it at the Mayo Clinic?
I guess I agree with Andy that I would be inclined to continue. I guess you could make an argument if there's only low volume asymptomatic bone disease, if a person wanted to get the little trial off study, but for most of these, I would continue them on somatic analogs.
Okay. All right, so we continued with MRIs mostly, and this is an MRI 1 year after surgery. As you can see, there was no residual disease in his abdomen that we could at least tell. Now, of course, this is a interesting case. We actually opted not to continue octreotide, also mostly because of patient preference. He felt really good. He didn't really thought that he needed it. But I do agree with Thor and with Andy as well. If you have extrahepatic disease, you could certainly consider it, especially if it's bone disease. But he was asymptomatic from his bone disease as well. Now, about 2 years after all of this started, he had a parotid tumor resection because he developed something in his parotid, a mass that was biopsied and thought to be some questionable malignant parotid lesion, but there wasn't really a good diagnosis on the fine needle aspiration. And lo and behold, now this comes back on final histopathology after the surgery's been performed as a metastatic well-differentiated neuroendocrine tumor grade 2 with a Ki-67 of 5%. So what do we do now? Well, I'll let Erik actually jump in here as a nuclear medicine physician. This would be probably a good idea to get a dotatate PET-CT. Would you agree on this patient in this case?
Like, you were biased with surgery, so I'm obviously biased with PET scan. So yeah, I would definitely agree that, and also I agree with Thor right in the beginning that that's something we would typically do right up front. And the other thing I just wanted to point out for everyone who's listening is that the dotatate PET scan can be done with gallium-68, as Thor said, but also with copper-64, which is now available in a lot of institutions as well. And I also advocate for the PET-MR, which he mentioned as well. But at this point, definitely worth restaging.
So how would you assess what I just showed you here?
Very extensive metastasis, pretty much, throughout the skeleton, it looks like. And then also, I believe, some lymph nodes that are probably within the abdomen, upper abdomen, and maybe in the chest. So very extensive metastasis.
So let's remember, he was not on octreotide for that period. You could argue it's been progression of disease of therapy, right? Because the patient, except for surgery, which is a localized treatment, has not had any real systemic therapy. So what would you do next? Erik, would you think that he's a good candidate for PRT up front? Or Thor and Andy, would you guys consider putting him back on octreotide first?
Yeah, we definitely want to be very careful in terms of using PRT because it is a very effective therapy, but something that you don't want to necessarily jump to. So I think at our institution, we would, number one, re-image with a CT or MR. While you're right that the dotatate PET probably clearly shows progression, it would be also important to kind of validate that with some other imaging as well. And I think we would probably restart SSAs first and see how that goes before moving on to PR.
Thor, would you agree with that?
Yep, I would absolutely agree with that. I would restart a somatostatin analog therapy, but it would be nice to have some sort of more anatomic cross-sectional imaging. Although with this amount of bone disease, I think we'll end up having to rely on the PET quite a bit.
Right. Andy, any
Yeah, I
recommendations?
think, having a few different time points of imaging to get us a better sense of the pace of disease, that's also important. And also seeing, how his symptoms, especially the carcinoid syndrome symptoms, have changed also gives us, a sense as well. But assuming he's clinically stable, then I agree with resuming the SSA and maybe with short-term re-imaging.
Great.
The patient's symptoms return during this time or no?
No, that was the interesting part. He actually, and his serotonin levels still stayed quite low. So it was actually mostly incidentally discovered really at that point. And to your point of anatomical, so he did get MRIs every 3 months, and we did not notice this enlarged like lymphadenopathy on the MRI. At least it didn't seem to be significantly different than what it was before. Okay, so 12 months after that dotatate PET CT, they obviously had like anatomical scanning every 3 months after we started monoclotide, but again, not much significant difference. But we did repeat a PET scan 12 months later, and this was the previous scan. This is the new scan. So how would you interpret that?
Yeah, this is again showing progression of the widespread metastasis that was seen before. This is a good example where, even on PET, you can definitely tell that there's progression.
Okay, so Oz, I have a question for you from an interventional radiology perspective. When you have bone disease like this, is there like anything you can offer these patients?
Yeah, that's a great question. As while you were loading that image and Erik was sort of talking about the progression, I was sort of looking at some of the areas that may be amenable to some of our therapies. Specific patients like this who have sort of extensive disease may not be ideal surgical candidates, especially when there's metastatic lesions to weight-bearing areas of the body, like the acetabulum or the hip, essentially a common area where patients may develop metastatic disease. And it looks like this patient is starting to develop that. There are some very cool, innovative things we can do now where we can do what I mentioned with percutaneous ablation, where we can either burn or freeze the tumor away, but then we can follow that by reinforcing that area with cement. So we call that cementoplasty with ablation. And we're now actually also moving towards placing screws using image guidance and minimally invasive. So avoids kind of a large operation for these patients who would probably not be ideal surgical candidates.
Great. Thank you, Oz. Obviously, in this case, he was asymptomatic from a bone disease, but I do think that your point is exceptionally well taken, especially for patients that actually do have symptomatic disease, especially if it's localized disease and if there's some significant weakening of the bone in that area, right? So in this case, we opted to move on to systemic therapy. What type of systemic therapies do we have available, Andy, and what would you recommend for this type of patient?
So PRT with lutetium dotatate is definitely FDA-approved standard treatment. There's also everolimus is another treatment. There's no head-to-head comparison. We kind of have to, kind of assess patient characteristics and everything and think about our ultimate goals. Given the favorable, benefit to toxicity profile PRT, usually this is a situation where I would recommend doing that.
Thor, any difference in opinion at Mayo?
I completely agree with Andy. I think this is a time you have to sit down with the patient and talk about the two different treatments that are approved. Keep in mind, though, that if I'm not mistaken, FDA has not approved everolimus for small bowel nets with carcinoid syndrome based on Radiant 2, which was a trial that barely missed sort of its target of being significant. That said, I think it's still a reasonable choice. I would say a PRT is I think, a much more effective treatment for this disease than everolimus is.
Erik, do we need to be worried about PRT when there's that much bone disease? Has there been any data? Do patients need to be worried if most of the disease is in the bone, that they will actually have a higher rate of problems with the bone marrow or a higher rate of radiation to the bone marrow and have a higher risk of developing bone marrow toxicity and maybe even malignancy?
Yeah, it's a really good question that I think, everyone should kind of discuss with their treating physicians, but it's a little bit of a dichotomy. It's interesting that the main thing that we worry about with Lutathera actually is bone marrow toxicity, primarily platelets decreasing, but sometimes some of the other cell lines as well. Having said that, the distribution of the disease in the bones doesn't seem to be a predictor for having that type of toxicity. In fact, there's been several studies where those patients with very extensive bone disease didn't have any correlation with worsening hematologic toxicity, and some patients that didn't are the ones that actually did. So we don't rely on that in terms of deciding whether or not to be concerned about that, but it is something that we follow very carefully for all patients. The other thing that I would just point out, at least again in our institution, is that we tend to be very careful in terms of treating only bone disease, because that doesn't tend to, ultimately kill the patient. And if the patient, in this case, as you're saying, is still asymptomatic, it's an odd distribution of disease. I can't tell entirely from these MIP images, but it doesn't look like any significant liver disease and maybe some nodal
Correct.
disease. So we would be kind of very thoughtful about whether or not this is the right moment. And in fact, maybe some of the more directed therapies that Oz was talking about, or also done by radiation oncology, those approaches might also be something to consider, at least to buy some time until you start PRRT.
Very good point. So he's had 2 cycles so far, and on repeat scanning, things looked stable. So that's for him right now. So we're going to jump to the next case. So this is a 62-year-old male who presents with a newly diagnosed pancreatic neuroendocrine tumor. It's a grade 2, Ki-67%, and it's a stage 4 tumor. The imaging always makes me a little bit not happy when radiologists comment on innumerable bilobar liver metastases. I always say, well, they don't spend the time to count the lesions. But this is a MRI that shows indeed that there's quite a bit of disease, as you can see here. So let's say the patient has between 50 and 100 lesions in his liver. And then he does have about a 2.5 centimeter lesion in the pancreatic tail. He's completely asymptomatic. This was discovered incidentally, so he has no symptoms. Andy, what would you do for this patient?
Well, it seems like, the patient should be considered for systemic therapy. And with small bowel neuroendocrine tumors, typically we choose a somatostatin analog like octreotide LAR or lanreotide as first-line therapy. But sometimes with pancreatic neuroendocrine tumor, sometimes we think of the ultimate goal of the patient too in centers with surgical expertise, especially with the intent of, if we're trying to get them to downstage to become a surgical candidate, then sometimes we may be a little more aggressive. But curious to see what other people think.
Thor, what would you start this patient on?
Yeah, so I guess you could make an argument for careful observation without therapy, but this is it's a grade 2, Ki-67 is 7%. Some of those lesions may even have a little bit of like necrotic center to them. So I'm not sure that this one will necessarily play nice. So I would, if the patient really strongly wanted to try without therapy, I'd be okay, and they would scan in 2 to 3 months. If there were symptoms present of tumor bulk, I would consider capecitabine temozolomide. I would not consider upfront PRRT unless that was done on a clinical trial. And then we have, obviously, if this lights up on dotatate imaging, we have octreotide, lanreotide, and then obviously everolimus and sunitinib, which I favor later. I would say either a somatostatin analog or capecitabine temozolomide based on symptoms.
Great. So he was started on somatostatin analogs and asked to return in 3 months for surveillance imaging. And the repeat MRI was interesting because it shows us that overall the liver lesions were stable, although maybe a few were mildly enlarged, but the primary tumor started growing. So the primary tumor went from 2.4 times 2.1 to 2.9 times 2.4 centimeter. So is this something we need to be concerned about?
So interestingly, we see this occasionally, and in the absence of symptoms, in the absence of bile duct obstruction, I might possibly just sit tight and scan again in a few months. And if this continues, everything is stable in the liver, but the primary tumor in the pancreas is just progressing, I would actually call up the radiation oncologists and see if they could possibly do radiation to this. I've done that occasionally.
Okay, Oz, when you look back at this liver here, I'm going to put this back to you one more time. Is this something that you can address with interventional radiology treatment, assuming that, of course, there's no widespread disease, that there's truly just a disease in the tail of the pancreas and in the liver? And if yes, what would you use?
Yeah, absolutely. As you mentioned, the report says innumerable liver metastases. However, if that's really the only site of disease outside of the primary lesion, this would be sort of an ideal candidate for some of our therapies. As we mentioned, it's local regional, meaning we can target the liver specifically, and as long as the liver function is okay, meaning that the normal liver is still functioning fine, which even with these number of lesions, it usually is, we can treat all these lesions, and usually that's through an intra-arterial method, meaning we'll take a catheter and go into the arteries of the liver and treat from inside. And these lesions are all hypervascular, meaning they suck up anything we inject from the arteries. So I would choose for a tumor like this with this many lesions and this hypervascular bland embolization, where we would treat the right lobe and then followed that with the left lobe about 4 to 6 weeks later. And so it'd essentially be two procedures separated in time by 4 to 6 weeks.
Thank you, Oz. So we actually opted to start him on CAPE-10. The reason why we did this is because we thought that there was some mild progression on octreotide, and we thought that even though, as Thor said, it's very reasonable to sit tight, I think, and to just wait another 3 months, we thought that the inevitable was probably around the corner, and that in the next 3 or 6 months it would progress further. So we continued SSA and started him on CAPE-10, which is a form of oral chemotherapy that is usually pretty well tolerated by most patients. Now, he started responding. So we scan our patients every 3 months while they're on chemotherapy. And as a matter of fact, his MRI a year later showed that there were very few lesions left. So he had a pretty drastic and amazing response to CAPE-10. Here's an example of where you could see multiple lesions. Now suddenly there are only 2 lesions left. So is this something, Andy, that you see often when patients have these type of tumors? And you start on like CAPE-10, are these the type of responses that you see often, or is this once in a blue moon?
So we definitely have seen this type of response. If you go by the data, if you look at the trial for pancreatic neuroendocrine tumor, the ECOG trial, about 1 in 3 patients will have an objective response, meaning, major tumor shrinkage. But in our experience, we have seen dramatic responses like this. And that's why, sometimes we kind of have to think longer term. What are we trying to achieve here? Are we going to make this patient become a surgical candidate for liver debulking like Dr. Keutgen does? And if so, then it may be worthwhile to give it a try and see if we can downstage them like this.
So, Erik, what do you take of this? What will you do now?
Just like the last case, I think with that type of distribution of disease, it would be a great idea to get a dotatate PET scan in the beginning to make sure that we're just seeing what we're seeing on the MRI is the extent of the disease and there's nothing beyond that. And then also the quality of the MRI is also important in terms of using hepatocyte-specific contrast agents, especially when we were talking about kind of small differences in size. Something like that would also be helpful. So the bottom line is kind of high-quality imaging can help guide, the therapy.
And I think when you talk about MRIs, we tend to use our scans with EOVIS, which is, a specific dye for the epithelial phase. And we quite often can detect more lesions on those scans than we can on a regular MRI with, like GATAVIST or even on a triple phase CT scan. So I do think that you make a really, really good point that ultimately you can only see what shows. And so you have to be aware that there are specific scans that you may want to use in specific situations to look at specific things. Very good point.
But if in fact the PET scan is showing no additional disease and the liver tumors are shrinking based on this therapy, what's the pancreatic tail mass? Did that change at all or no?
It did, yeah. It went down to about 1.8 centimeter from 2.9.
So I think that's a really good response, and I agree with your comment also that potentially, at least in our institution with Dr. Pommier, we would definitely probably consider some surgical approaches there as well.
What about you, Thor? What would you do in this situation at Mayo?
So this is probably what they have sometimes called like an exceptional responder, and this is a term I think comes from Memorial. About half of these will actually continue to have a response even beyond 12 months if the treatment is stopped and they don't really fully understand why. But here I think, as was hinted at by Erik, is that now the question is, do you believe that resecting the primary tumor will alter the eventual outcome? Essentially, will the patient live longer if you go after the primary tumor? And as we well know, pancreatic surgery is not a small deal. I would actually run this by my surgeons now.
Okay, now this is what we did. And the surgeons in this case, which was me, uh, but of course with Andy's blessing at Tumor Board and Oz blessing too. So we decided to go to the operating room. We did a distal pancreatectomy, splenectomy. Actually didn't find that many liver lesions, about 15. So you can always usually find more in the operating room that you actually see on the scans. So we ablated 6 and we resected 9. We also did a cholecystectomy since we did anticipate that he may go on octreotide long term. Now, interestingly, the preoperative pathology showed it was a grade 2. The postoperative pathology, and this is both the liver and the primary tumor, showed a grade 1 tumor. So, can you comment on that, Andy? Is there heterogeneity in these tumors when we biopsy them, or even when the pathologist looks at them? Or is it the chemo that downstaged or downgraded these tumors? What do you think?
Yeah, definitely. I think, these tumors are heterogeneous and sometimes just depends on where you biopsy. You may get two slightly different grades or, tumors also evolve over time, through chemo, through different treatments, and sometimes biology may change and their pace may change too. So it's definitely very interesting. And we have seen, discordance between somatostatin receptor expression as well between like primary tumor sites and metastatic sites, and etc. So
Great. Now, what now? Should we start him on like SSA post-op? Remember, he was on SSA pre-op, had some progression at least of his primary tumor. Is it worth continuing SSAs, Thor, or should we just wait and see? Or what would you do?
I would probably not do anything for 3 to 4 months, and then I would love to see a dotatate PET MRI with a hepatobiliary contrast. And I probably wouldn't do anything until it starts moving again.
Okay, this is what we did. We did nothing. We scanned him every 3 months, of course, and a year later, everything looks pretty good. So now we know that this patient will probably recur, right? Because we know that once the cat's out of the bag and the tumor has metastasized to the liver, as a surgeon, I can't cure him. Oz usually can't cure those patients either with this liver-directed therapy. Now the primary is out. The biology seems to be favorable, at least like on the pathology from the surgery with a low-grade tumor. But this patient will recur at some point. And if the patient does recur, Erik, would you think that because he didn't really respond well or didn't have stable disease really on octreotide, you would move right up to PRT? Or would this something be dependent on where he recurs? If it's in the liver, maybe liver-directed therapy. If it's outside of the liver, then maybe something more systemic. How would you address this?
Yeah, so basically the eligibility for PRT depends primarily on imaging to show that there's high somatostatin expression homogeneously across all the sites of the disease. But then secondly, definitely on the distribution of the disease as well. If it is again primarily within the liver, we would typically at our institution consider liver-directed therapies that Oz does first. And if that doesn't provide enough control, or if there's extensive disease outside of the liver, then yes, we would probably move to PRRT. I don't think there's probably a role for retrying SSAs because he progressed on that previously, but I don't think it would be wrong either, at least for a short time with imaging to see how stable you can make it.
Andy, do you have any comments about this?
I think it just depends on the pattern recurrence, localized versus widespread systemic, but also, the pace of the disease. If we see that the disease explodes, then you may want to consider actually rebiopsying and see what's different about it,
What do you mean by that?
Sometimes we have seen that, tumors change in biology. We have seen patients with well-differentiated tumors for different treatments. Suddenly their cancer starts to behave more aggressively. And when we did a biopsy, we found out that actually there was a clone of much higher grade disease. We have seen patients who have, for instance, originally a grade 1 or grade 2 tumor, and when you rebiopsy, the KLC7 is like 60%, or they become fully differentiated. And as those would be more appropriate to consider cytotoxic chemotherapy.
we always correlate the PET scan, DOTA PET scans with the anatomic imaging that we see. And I mentioned that everything needs to be heterogeneous on that scan. If we see certain areas that don't show high uptake on the scan or differences, then that's especially kind of indicative of what Andy is saying, and we would specifically go and biopsy those areas that show differences and not high uptake, because they may have gone to a higher grade.
Very good point. Thor, would you agree with the statement that it's important for patients to understand that there are a fine amount of therapies, that these therapies generally tend to work well, but that, like you said yourself, sometimes we just sit tight and wait because there's no rush of trying to use these therapies in a rapid sequence unless we absolutely have to, right? Is this something that, do you see it the same way, to try to use the right therapy at the right time? And sometimes we take breaks and we just watch.
Oh, absolutely. I don't think we have the data to suggest that that continuous therapy necessarily leads to prolonged survival or longer life expectancy. I completely agree with Andy. I would have a low threshold for biopsy. Sometimes even a biopsy could make a patient eligible for a clinical trial. There are PRT trials now looking at patients with Ki-67 more than 10%. And we could consider, in the unlikely event we found an actionable alteration, we could consider a trial for that. But the good thing here is actually we have a number of reasonably effective options. And I don't know,
Right.
and I think this case beautifully illustrates the constant headache we all have regarding sequencing therapy for metastatic pancreatic mets. There is no right answer typically.
Right, because I would completely agree. And this is about sequencing, right? I mean, we could have just branched off in a completely different pathway by just saying, well, the hepatic lesions, which is probably the most important prognostic factor for this patient, did not significantly change after the lanreotide therapy here. But the primary tumor grew a little bit, right? So we could have just, like you said, continued octreotide, and we could have maybe give external beam radiation to the primary, or maybe just watch it for another 3 months or another 6 months. And then maybe if he would have progressed, we would have just gone to PRT. I think that would have been a reasonable therapy as well. I don't think anybody would say that it's not like appropriate to start PRT if you have progressed on long-acting octreotide. Not everybody needs to go through CAPE-10 up front, right? So I think, and they're always concerned also that if you plan to give PRT, right, and somebody has been on CAPE-10, that their bone marrow can take a little bit of a hit while on CAPE-10. We see that sometimes. And then you have to delay PRT. So I think these are all decisions that we all do on our daily basis, and that are maybe very different for one patient and may also change for another patient. It really depends on a lot of things. Some patients are not interested in surgery. Some people really want surgery, and then we know that we're trying to downstage them as quickly as we can to get them to surgery. I think these are really important questions that we brought up today by showing that this treatment sequencing arch here is really something that is not just institutionally dependent, but also dependent on like the patient, the tumor type, how is the patient doing, how's the tumor, right? What biology is the tumor, et cetera, et cetera. So I do think this was really important, like for our patients to understand how we discuss these patients at tumor board. And I'll ask maybe each one of you to just give a final word because I've talked way too much. Thor, is there anything you want to add?
No, I would just emphasize the importance of tumor boards. So I do this for a living, and every week I have to phone a friend because there is a situation where I'm not sure if I necessarily have the best plan. So just make sure that don't let your ego get in the way. So this is a team approach.
Erik, any comment?
I completely agree with that comment. I mean, I think these were great cases to show just how complicated, things can be, and there aren't clear answers in terms of sequencing. So just as Thor said, so important to, work together with all your colleagues from all the different specialties and get everyone's input. And that's really the best way to do it.
Oz?
Yeah, I'll go ahead and reiterate that. I think from this tumor board, I think we've demonstrated that your options are highly variable. They can range anything from just careful surveillance all the way up to surgery. So I think making decisions in a vacuum or a bubble, without the input of other is highly discouraged because it's really important to sort of get multidisciplinary input. And I think a lot of our treatment, specifically in interventional, may impact potential future surgery and things like that. So it's very important that everybody sort of makes these decisions together.
And finally, Andy.
Yeah, and going on that, if you don't have access to a multidisciplinary team, then we at one of our multidisciplinary institutions are happy to help out and collaborate with your local doctors.
Very good point. And I think this is what NetRS is about too, is to give you access to, like specialty centers. I would highly encourage second or third opinions. Nowadays, things can be done virtually, right? Quite often, so you don't even have to travel. So if you're not sure about the treatment you are getting locally, I would highly encourage to go see one of us or like one of the multiple specialized net centers that we have in the United States. So I'll close this up. Thank you so much to our panelists. I think this was a really, really great discussion. I hope that our patients and the families of our patients will enjoy the treatment sequencing panel discussion, and we will see you very soon. Thank you so much.